Hi everyone. Thank you for joining and just giving people time, just to join the call here. Appreciating that we're slightly late starting this one anyway, and that was just a technical issue, so apologies. I think we are now all here, all present in terms of our speakers, and got the slides ready. Lovely to see some familiar names in the delegate list as well today, and people who've been with us for the last couple of weeks, which is lovely. I know that lots of people have been catching up online afterwards as well, and we've had really good audience figures afterwards. So please do provide feedback to Charlotte and on the link at the end, because it helps us shape what these will look like in the future and how helpful they are to you and target the audience really. So Mick, if you want to share the first slide, please. Yeah, it's the fourth and last of the Community Oncology webinars that we're hosting between Velindre Cancer Centre, Cardiff University and Macmillan Cancer Support. Once again, grateful thanks to Macmillan, who have provided all the funding for this in order that you can attend for free today, which we're very grateful for. Today's update is a Gynaecology update, and we've got a really full and interesting set of talks from 4 different presenters, all working in South East Wales. So their talks will be relevant to local practice, but obviously where relevant, if you're not local, please do look at your local guidance or speak to your local teams. In terms of who's present on the call, you've got myself, Dr Fiona Rawlinson and Dr Mick Button, who've been involved in hosting these conversations and webinars so far, and then Charlotte Stevenson, who has been your go-to person for the admin side of things. Charlotte, if you've just launched a couple of polls for me, please. For the audience members, if you just would take a minute just to complete these polls about where you work and who you are. It's just very vague, just to keep the speakers aware of who they're talking to, appreciating obviously that for the audience who watch online later, we won't know their roles, but lovely. So far, people have completed mainly GP trainees, nursing team, and palliative care team. And then Charlotte, the next slide about where people are based, whether you're in the community or in hospital settings. Thank you to those who are completing it. Lovely. And the very last question is just about where in the world you are, because it's just interesting to know who we're reaching out to, and whether we do have any international delegates as we have had in the past, or whether everyone's in Wales or parts of the UK or whereabouts people are attending from. So a lot of Welsh delegates today, and one from Northern Ireland, which is great. Everyone's very welcome. As I say, we try and keep the talks about best practice, which may or may not have a sort of slant of what goes on in South Wales, but you can obviously check with your local specialities as well. Fabulous, thank you. Thank you, Charlotte. If you want to close the poll down, and Mick, just move on to the next slide, please. Yep, so welcome from all of us. And then the next slide, Mick, which just tells you about today's speakers. So we've got consultants from different specialities. We've got Ms. Sadie Jones, who's a consultant gynaecologist in Cardiff University Hospital. Dr. Louise Hannah and Dr. Emma Hudson, who are both oncologists in Velindre Cancer Centre in Cardiff, and Sarah Burton and her colleague who are specialist nurses in Velindre Cancer Centre. So lovely. Without much any more fuss, I shall hand over to Sadie, who's going to do the first part of today. Thank you ever so much.
Okay, hi there. Everybody can hear me, I presume. I'm not on mute. Yeah, good. So thanks for having me. I'm Sadie Jones, as Elise said, and I'm one of the gynae cancer surgeons in University Hospital of Wales in Cardiff. So we're going to just talk mainly about diagnosing and referring gynecological malignancies, and a quick touch on optimization of patients right at the end. But I think the first thing I would like to say is that writing this talk has really emphasized to me the difficult challenges that must be faced very frequently with these grey areas for referral all of the time, which we'll touch on going through the talk, and I definitely think need to be a focus of how primary care and secondary care work together going forwards. Who moves the slides? Do I do it? It looks like I do it.
Mick's on the case, Sadie. If you just say next slide, he'll change it for you, which he has done.
Lovely, thanks. So first of all, we're just going to give a little background of vulval and vaginal cancer together, because the symptomatology is very similar. The way we investigate is similar, and the referral process is similar. So vulval cancer is one of our rarer cancers. We only see 1,372 cases in the UK in 2016-18. We know it's a cancer of the older age group. It peaks in women when they're much older in age. And the trend for vulval cancer is generally increasing, and this is obviously because of HPV. And actually, a very recent paper has come out demonstrated that despite the benefits that are being seen with cervical cancer decreasing as a result of HPV vaccination, we're not necessarily seeing the same with pre-malignant malignant disease of other anogenital sites. Next slide. So the symptoms that are associated with vulval cancer, I really don't want to teach any of you to suck eggs, but I think we all know persistent itching, pain, bleeding, the sensation of a lump down below, change in appearance of the skin, dysuria, a swelling or a lump that's palpable in the groin, and abnormal discharge. So any patient presenting with these sorts of symptoms would typically trigger a vulval examination and a vaginal examination and potentially cervical examination as well. Next slide. Then we have vaginal cancer, which is very rare, only 250 cases in that time frame reported. Again, it's a cancer of the older age group, and generally this is a rare cancer. It's very difficult to work out how the trend is changing over time, but it seems to be stable over recent years. But it is a very rare cancer, and I think that for both of these cancers, it's very difficult in the world of general practice, because obviously you're going to see one every now and again, once in a blue moon in your career. So it's really difficult to become expert, I guess, in the all of the other kind of vulval skin conditions that present that may sometimes look like cancer, and being able to pick out those ones that actually are. Next slide. Symptoms are very similar to vulval cancer: the itching, the pain, the bleeding, the lump, the change in the appearance, dysuria, and abnormal discharge again. So the examination being similar for the presentation for vulval and vaginal cancer. Next slide, please. So the investigations that ideally need to be carried out in primary care when we've got this series of symptomatology are the vulval examination, which doesn't require a colposcope and the kit necessarily that we've got in secondary care, but it does require a careful look and looking in between all of the skin folds for any change that you might see in colour or the skin architecture that might trigger or might help you identify what the condition is or trigger a referral into secondary care. The speculum examination is important for looking at the cervix, particularly when there's an abnormal bleeding pattern, but also looking at the vaginal mucosa as well. So it's the vagina and the cervix. So ideally when you're removing the speculum from the vagina, doing it slowly and gently rotating it so as you can look at the vaginal mucosa as well. A vaginal examination is also important because with the best will in the world, when you slide a speculum into the vagina, you will sometimes run it over lumps and bumps and not then pick them up as you're pulling the speculum out. So the vaginal examination will help you identify thickened areas of the vagina, rough areas, even lumps and bumps that you wouldn't have felt otherwise. And of course, any lumps and masses that might be palpable in the pelvis. And then of course, your swabs for infection. Itching and discharge and bleeding are also very common symptoms associated with infections. So if the history indicates that the swabs are required as well, it's a good time to take the swabs, not only for the sexually transmitted infections, but also for candidiasis and bacterial vaginosis. Next slide, please. So I think when you're doing these examinations, you're going to end up in one of a few different situations. Most commonly, I suspect you might find that there's nothing there. You don't see anything. And often that can be quite difficult because the patient's got the persistent symptoms, and it's about reassuring them and helping them manage the symptoms that they're experiencing, and also asking them to come back should they be persistent and concerning in any way. But in terms of more pathology associated things that you're going to find, the other very common thing would be atrophy, which is when the skin becomes thinned and vulnerable as a result of loss of estrogen. So the skin will look dry, it will look thin, it will look shiny, and it will be very vulnerable during the examination process and often bleed with minimal contact. And these are the situations where topical estrogen creams are required. And certainly from the referrals that we get in, this is very commonly the outcome after the assessment in secondary care, but certainly something that can be managed in primary care, of course. Infection is going to be something that will be identified reasonably commonly with the presenting symptoms, particularly in patients where the clinical history is indicating that this may be the problem. But of course, looking for things like excessive discharge at the examination, which may be offensive or not, thinking of the sexual history, looking at those classical features like the strawberry cervix that you see and other signs of inflammation. This orange box down fourth along is probably the biggest problem area. So those skin dermatoses and lumps that are not thought to be a cancer, but equally we're not sure what they are. So it might be that the vulva has patches of discoloration, that there's loss of the normal skin architecture. Maybe you've got plaques which are shiny and flat, or rough, rugged surfaces. There may be excoriations from excessive scratching or thickening with lichenification that's happened with prolonged inflammation and irritation. And I think that this is probably the big grey area and the real difficult area. It's not only difficult in primary care, mind, it's also difficult in secondary care to kind of get to the bottom of these patients and work out what's going on. And then, of course, the red at the end are those patients where you look and you think that there's a lump or a lesion which is highly suspicious of a malignancy in the vagina or the vulva. And of course, these are those patients that require that USC referral, which typically in the UK is a 2-week referral. So obviously any lump in the vulva or the vagina which is suspicious of cancer requires that referral in. But this orange area we'll just perhaps try and explore a little bit more in the next slide. We've obviously only got 10 minutes for this talk, so we can't go into anything in an awful lot of detail, but I think the most common skin dermatoses that we're going to see when we're examining a patient with these sorts of symptoms are your lichen sclerosis. Certainly this is going to be the most common condition that you're going to see. We've got 2 pictures there on the left-hand side where you see that whitening, the thickening, the lichenification. You get a figure of 8 distribution of the condition. You can get fusion. You can see in the top picture there, you've got fusion of the labia minora that's happened. And this is certainly a very common skin dermatoses that can look fairly indolent, as in these pictures, but when it's very poorly controlled, it can look really very, very aggressive, and certainly can be confused well, not confused, it can certainly look like a cancer or a precancerous condition very, very easily, and commonly is a reason for a referral into secondary care for better assessment. It actually doesn't need a biopsy for diagnosis. This in most instances should be a clinical diagnosis based on the kind of classical features that you're seeing when you're examining the patient, and is managed with potent steroids initially and then with maintenance steroid therapy thereafter. And all of that can be done in the primary care setting, of course, but is frequently done in the secondary care setting, and a good relationship between the two for ongoing management after initiation of therapy is often what's required. On the right-hand side of this slide, you've got another condition, vulval intraepithelial neoplasia. Now, this can result from, of course, lichen sclerosis. You can get a form of VIN called differentiated VIN, but it can also be a result of HPV chronic infection. Now, this can be quite subtle, and it can be really hard to identify, but sometimes it can be really obvious and also look very much like a cancer. And I think probably an area where it can be worrying that you might be missing something, certainly whether you're in primary care or secondary care, that's for sure. It does require a biopsy for diagnosis. So whenever you see skin changes which are suspicious of VIN or premalignant disease of the vulva, this certainly does require a referral in on an urgent basis for secondary care assessment. The sorts of skin features that you're looking at are, you'll get discrete lesions typically, and the skin will often be raised and you will lose the normal skin architecture. It's not normally in a complete shiny flat way. You'll often get irregular surface markings on the surface of the lesion that don't match the surrounding healthy skin. It can be any color: white, pink, red, brown. It's really, really heterogeneous in the way that it presents, and I think that's what makes it so challenging and so difficult for people to be confident in diagnosing it and managing it as well. But I think in that orange group from the previous slide, and these are typically the more common things that you're going to see in that orange group, if there's any concern that there could be a pre-malignant skin condition there, the patient needs to be referred into secondary care. There's no doubt about it. And I think that I would say that in the referral into secondary care, that there is a lesion that you are suspicious of a pre-malignant condition going on. And I think that makes it very clear then to the recipient of what the thought process and what then needs to happen as well. Next slide, please. So I'm going to touch very quickly on cervical cancer, because I know that Louise Hannah's going to do a talk on cervical screening later on. And of course, by far the majority of the cervical cancers are being identified that way. Fortunately, it is a cancer that's on the decline thanks to very successful HPV vaccination. We see 3,197 cases each year. And 99% of these are preventable still. So I think that that's something that we still need to be obviously working harder to achieve. Next slide. So, oops, sorry, next slide again. Oh, are we going backwards? Yeah, okay. So cervix cancer, again, this is a brief touch because I want to talk about uterine cancer and ovarian cancer really. The symptoms typically unusual bleeding, dyspareunia, so painful intercourse, vaginal discharge, and pelvic pain, that's meant to say at the end there. If you have a patient outside of the screening program that's coming to you with these symptoms, of course, the same examination needs to take place, the speculum, the vaginal examination, and the abdominal examination. And that's obvious, you all know that. But ultimately, if you see an abnormal looking cervix, or you palpate an abnormal looking cervix or a mass, then an urgent suspected cancer referral needs to go in. And most hospitals do have capacity for an abnormal looking cervix clinic actually that runs within their colposcopy services. Of interest to you, in Cardiff last year we had approximately 1,000 cases referred in for an abnormal looking cervix, and I think we had 3 cancers come from that clinic. So it is something that, again, working out how we're going to get this right between primary and secondary care is certainly a focus of work that perhaps needs to happen in the future as well. Next slide, please. So uterine cancer. So uterine cancer is our most common cancer. And certainly a lot of the feedback into when this webinar was being developed was about trying to understand the referral processes for those patients in the perimenopausal phase where they're getting, abnormal bleeding patterns and, when you should and when you shouldn't refer in. So we'll try and touch on that a little bit today, but it is without doubt a grey area and very difficult. We see 9,700, nearly 10,000 cases per year, and we think that 30 to 35% of them are potentially preventable. It's a sad figure to hear that 1 in 36 women will be diagnosed with womb cancer in their lifetime, and the incidence is increasing in the UK population. And the general consensus is that that's largely a result of increasing levels of obesity. And I'm sure you all know that a lot of these cancers certainly have an estrogen drive to them. And of course, when a patient is more overweight, they're producing more estrogen, and consequently they get excessive proliferation of the lining of the womb and an increased risk of womb cancer. So any patient with obesity is at an increased risk of developing womb cancer. And this is largely why a lot of the cases may be preventable, and certainly, again, a focus of where we need to focus public health messages going forwards as well. Next slide, please. So the symptoms, it's abnormal vaginal bleeding. And if it's postmenopausal, it's easy because postmenopausal bleeding is a red flag and absolutely requires that USC referral into the hospital for a 2-week assessment. That can happen largely without much investigation from in the primary care setting, because at that appointment they will have an ultrasound scan and a biopsy taken to further evaluate the situation. The difficulty, of course, is those patients where, they're not postmenopausal bleeders. So they're premenopausal patients or perimenopausal patients where maybe they've got an irregular bleeding pattern, or they've developed an abnormal bleeding pattern, or they've got heavy menstrual bleeding, which is not responding to typical medical managements. And this is the far more difficult group to treat. It can also present with less common symptoms of a persistent vaginal discharge, pain, change in bowel habit, and altered bladder function as well. Next slide, please. So investigations obviously are the same: vulval examination, speculum examination, and vaginal examination. Postmenopausal bleeding can be caused by vulval atrophy and commonly is caused by vaginal and vulval atrophy. Certainly when the patients come through our PMB service in UHW, atrophic changes is one of the most common problems identified and then treated. The full examination of the lower genital tract is really useful to try and understand where the problem might be. But of course, although it's a red flag for womb cancer, it can be associated with any of the lower genital tract malignancies as well. So the thorough examination is required for all these patients. Next slide, please. So it's all about this grey group in the middle. So not a postmenopausal bleeder, but a pre or perimenopausal bleeder where the pattern is not right, and you're not happy that it's just benign, for want of a better word, heavy menstrual bleeding or a bleeding pattern that you can manage in primary care. You worry that there might be something going on. I think the approach to take is to think of the risk factors for endometrial or uterine cancer that will increase that patient's risk of developing those cancers. So particularly you're looking at your tamoxifen use, your patients who have got Lynch syndrome, patients who've got polycystic ovary syndrome because they're getting increased ovulations and cycles, so that proliferative effect is happening more commonly and frequently. And those patients who are obese. So if you've got a patient sat in front of you and they've got this abnormal bleeding pattern and they're overweight, or they've got any of those other factors, the alarm bells can start ringing that a little more readily, that hang on a minute, perhaps we need to be thinking a bit harder about there being a malignancy here, rather than there being just a benign cause for the bleeding pattern that they're experiencing. Then, of course, you've got those patients that you are treating already who may not be responding to the treatment. So particularly those patients who are obese with PCOS, if they're not responding to the medical therapy, then that absolutely has to raise the alarms for further investigation for there being a uterine cancer. And again, the patients with the intermenstrual bleeding or the irregular bleeding patterns that develop over time, if you're certainly factoring in these additional risk factors, it might just raise your suspicion of there being a malignancy. So I think that the message really needs to be is that we have an urgent referral pathway as well. And if your patient is sat there with these sorts of symptoms and you are putting together these additional risk factors, they should be referred in for an urgent referral, and make it very clear the symptom that the patient has got with these risk factors. You're concerned that there's an elevated risk of malignancy and further evaluation is required. So they don't necessarily fit the USC referral criteria, but they certainly fit a raised suspicion of index group of patients. Next slide, please. So then finally, we have ovarian cancer. So ovarian cancer is our second most common gynecological malignancy, 7,500 cases per year. And generally we see this in women around, well, it says here 75 to 79 years of age. And it's remaining roughly stable in terms of the incidence over time. Next slide, please. So this is, ovarian cancer is probably our biggest problem cancer in terms of getting the diagnosis done early. Fortunately for womb cancer, our most common when we do get it diagnosed, typically it's stage 1 disease when the treatment is obviously very efficacious in most instances. But ovarian cancer is quite the opposite. And we're seeing that approximately half of the patients are presenting with advanced stage disease. And by this time, actually, the treatment is largely, well, it's improving in its efficacy, but certainly treatment is extremely challenging and the prognosis is not excellent at all for these patients. So it is, of course, difficult, and everybody on this call is aware that diagnosing ovarian cancer early is difficult, but certainly making sure that we adhere to the referral pathways is one way that we can make sure that we're all doing our best, I guess, and receiving referrals in the appropriate way too. So I think that the symptoms that we all are aware of, you know, your frequent abdominal bloating and swelling and pain and pelvic pain and loss of appetite and early satiety, urinary problems, bowel dysfunctional problems, fatigue and unexplained weight loss. These are all the symptoms that patients will typically report when they've got an ovarian cancer. And the guidelines state actually that frequent reporting of those symptoms basically equates to greater than 12 times per month. I'm not sure how helpful that is at all, really, but they do even give it a figure in terms of referral in for actually, describing what they consider to be frequent. But if you get a patient coming in with these symptoms, as you all know, a CA-125 is what's required. And in addition to that, certainly at the very least, an abdominal palpation in primary care is also required, because if you palpate a mass in the abdomen or the pelvis, that is an immediate USC referral in. And of course, I think everybody on the call is very aware of that. And arranging for a CT scan in conjunction with that referral in is often very helpful as well. So the CA-125 is the test that happens when you don't palpate an abnormality, and this one is the one that then has lots of different branches dependent on the results that we get. Next slide, please. So if the CA-125 is 35 or greater, then this is what triggers your ultrasound scan. And if the ultrasound scan is suggestive of gynecological malignancy, then obviously you've got your urgent suspected cancer referral and the patient needs to come into the hospital. If the CA-125 is 35 or greater, but the ultrasound scan is not suggestive of a malignancy, it may well be that it's suggestive of another benign gynae pathology, in which case a referral in is appropriate. But if it's not showing any form of pelvic mass or any pathology at all, then the guidance is to repeat the CA-125 in 3 to 4 months' time and reassess the situation then. If the CA-125 is normal based on the symptoms that we've had the patient describing in the previous slide, then the guidance is to go back to the drawing board and assess for other clinical causes and carry out investigations as appropriate. So a lot hinges on this CA-125 test, and I think that it does leave that group of patients in whom you have got that suspicion that there is something going on, but the CA-125 is normal and you can't pin it on anything. And I think that this is a really, really difficult, challenging group of patients that probably we have not got the right pathways in place for in many centres, and perhaps the rapid diagnostic centres that are demonstrating great efficacy need to be rolled out in a bigger way. Next slide. So it's not long to talk about actually what is something we could go into in each of these cancers in an awful lot of detail, but I hope it was a summary of the pathways that we have for referring these patients. I think one thing I'd like to say is that when you're referring a patient in on a USC referral, obviously we have it in our mindset that that patient is potentially going to have a cancer and going to embark on some cancer treatment. So there is a huge drive for prehabilitation and optimization of these patients before they're coming in. So if there is an opportunity in primary care to consider any polypharmacy, to optimize any medical conditions, smoking cessation and identification of anemia, then any opportunity can be taken to work on those things. There are pathways in secondary care now that are being developed to get all these patients prehabilitated and optimized during their treatment, but if we can get them that bit earlier, then all the better. We know that if we can improve patients' psychological and physical health before embarking on their treatment, then their outcomes are going to be better and they're going to be able to tolerate the treatments better as well. So think optimize when you have the opportunity to do so. Next slide, last slide. So really, just with some final thoughts, I think that, the referral pathways exist. They're quite concrete, and, obviously there's lots of grey areas and patients that don't fit into these boxes that we depict in all of the guidelines. But thinking of the risk factors for the cancers and adding that to the picture is something that is often quite useful when we're receiving the referral in to really understand the risk that patient might have. Certainly we need quality improvement projects and ideas to improve the working between primary and secondary care to enhance this whole relationship we have with these patients coming in and back out of our services. And we need better use of technology, without a doubt. I was at a fantastic talk from Moondance last night talking about different technologies that we can utilize. And I think that these are areas that we all need to be working towards together in the future. So I know that was fast and a bit of an overview really of the situation, but I hope it was helpful. Thank you.
Sadie, thank you so much. It's Fiona Rawlinson here. That's really clear and fantastic slides. And I'm sure people viewing the session after the session, when people view it on YouTube, it will be similarly helpful. We've got time. We've got two very specific questions. If I could ask them now, if that's okay, before we go on. The first was, when you were talking about uterine cancer symptoms, altered bladder function. Could you just expand on that a little bit? Did you mean just frequency, dysuria, or was there any sort of particular pattern to it?
No real pattern. Typically, yes, frequency would be the symptom, and that's because of the pressure effect. So this is it's really unusual for a patient to present with that symptom, but we do see it sometimes, particularly if there's a cervical stenosis and the patient's not able to bleed and show themselves that way. You know, the cancer can present then at a later stage. You get that mass effect and that pressure on the bladder. So then, of course, it's frequency and frequency really, and an urgency of passing urine. So yeah, it's a rare, but it's a symptom that patients do experience.
Great, thank you very much. And the second question just is again around CA ovary. If CA125 is normal, but the GP feels an ultrasound is warranted, can that still trigger a referral?
Referring into secondary care, not necessarily, but certainly an ultrasound scan in the context of primary care, absolutely. I think that if there's a clinical suspicion of a concern, then absolutely an ultrasound scan is warranted. CA125 is not elevated in all malignant patients, and certainly not elevated in all benign pathologies that may still require intervention. So absolutely.
Thank you so much. Singh, thank you for your comment on the question and answer. I'm going to suggest, if we can, that we move to the next speaker. And Sadie, if you've got time, Singh just put something in the question and answer if you're able to get in and answer it. But thank you so much indeed. That's been really, really helpful.
No
if we go on to our next speaker, and Mick, thank you so much. You're still on slide duty. So can we
Hi,
just
everybody.
Great, Emma. We can see you fine. Can everybody hear Emma fine?
Good. Can you hear me? I'm
Great.
not on mute, so I think you should be able to.
Thank you so much, Emma.
So I was asked to talk about the symptoms. Thanks, Fiona. I'm Emma Hudson. I'm one of the oncologists in Velindre. I was asked to talk about the symptoms of gynecological cancers and the symptoms of the toxicities that the treatments that we give cause, all in 10 minutes, which is a little bit of a mean feat, and each of those could be a lecture on itself. But I'm just, to be honest, when we started talking about this webinar, I thought one of the most important thing was the referral pathways. So I'm just going to touch on it briefly. I know Sadie's done it in much more details, but I'm just going to highlight a few things that I think might be pertinent to secondary care, and then I'm going to talk about some of the more novel systemic treatments that we've got, and again try to make it relevant to the toxicities that you can see and manage in primary care, and when you should need to refer these patients in. And as Sadie's already alluded to, I think the most important thing is communication between us and you, so to speak. It's really, really important that those communication channels are open. Certainly, I want to know if any of my patients have any sort of toxicities from treatments that I've given that are significant. So I think that is one of the most important key messages as well. Next slide, please. Right. Thanks. So in some ways, we have it really easy in secondary care, don't we? Because you've already done all the hard work. How you pick out the patients that you need to further investigate amongst all of the far more common patients that aren't going to have a malignancy is really, really difficult. We obviously get late diagnosis, and I think some of the things that we're told that those patients get frustrated about are the lack of an examination. And I know we're in difficult times, aren't we? We're still out of COVID, and it's more difficult than it was during COVID in some ways. But with ovarian cancer, the symptoms that the patients can present with are so heterogeneous, aren't they? It can be absolutely anything. I saw a lady a few weeks ago. She was in her mid-70s. She was the main carer for her husband, who was disabled, and her only symptom was fatigue. And she only presented a couple of months ago to her GP. And so with the only symptom she had was fatigue. and she had a lot of other reasons for being fatigued, apart from being the main carer and elderly. She was hypothyroid as well. But the GP actually examined her abdomen and pelvis and found a pelvic mass, which I thought was just absolutely phenomenal, to be honest with you, because in a busy general practice clinic, that GP could easily have not examined the patient. As I said, the only symptom she had was fatigue. So it's just really about the heterogeneity of how these patients present and the importance of examination. So how does NICE help us in terms of when the CA125 should be checked? Well, NICE say that if anybody over 50 has persistent symptoms of one or more symptoms for more than a month, then a CA125 could be checked. And those symptoms range from everything from IBS symptoms, from bloating, from abdominal pain, all the symptoms you would expect. So if anybody has symptoms more than a month, which really isn't very long, a CA125, a definite group of patients, particularly in young patients actually, where the CA125 isn't raised. So I guess the key message is here: if the symptoms persist, even in the absence of an elevated CA125, the patient still needs to be investigated further. Next slide, please. So I'm not going to talk too much about endometrial cancer because Sadie's covered it. The only thing I'm going to say is that we had a very interesting discussion with a professor of general practice at the British Gynae Cancer meeting a few years ago, where he was trying to defend the fact that patients shouldn't be examined in primary care because A, it's awkward if it's a male GP, B, there just isn't adequate time, and C, they don't have the adequate facilities. And it's patients find any of those excuses very, very difficult to accept, to be honest with you. And an examination doesn't take very long. I know the appointment times are short, but it really, really doesn't take very long. And it's a minority of patients who won't see a man. There are some, and they're often associated with different cultures or many other reasons, and that obviously needs to be massively respected. But the majority of patients will want to be examined by anybody. The key patient group here that's difficult, as Sadie has said again, but just to highlight it again, are the patients with premenopausal bleeding. And we've had quite a few patients who've been diagnosed with polycystic ovaries or written off just by particularly patients who've got raised BMIs actually. And that is a difficult group of patients because they are a little bit more difficult to examine. But as Sadie has alluded to, they're at much greater risk of endometrial cancer. And again, they do need to be examined. And early referral. Next slide, please. Just one thing to point out here, just about cervical and vaginal cancer, is just the patients who aren't able to have smear tests. And Sadie's already said a lot about the how the incidence of cervical cancer is reducing. And that is absolutely true, and it's fantastic with the vaccination programs. But there's still a big group of patients that we aren't able to access. And those patients that don't accept the vaccine tend to be the same ones that don't go for smears. And they tend to be the patients who are at higher risk of cervical cancer. So often that's those patients who've got cultural reasons, or are in deprived areas and don't have access to the service or don't have the time to go to have these things done. And also the LGBT community, some of those find it very, very difficult to accept smears. And then you've actually got patients, I know Dr. Hannah's going to talk about a bit later, so I'm not going to discuss, but patients who physically aren't able to have smears as well. And they're just, they just need to be flagged, don't they? If those patients have symptoms, they're obviously more at risk of a cancer. Next slide, please. Next slide, please. Thank you. I think Sadie's covered that, so in the interest of time, we'll skip that one over. Thank you. Next slide, please. Right, so in terms of, we obviously use weird and wonderful medications that are difficult to pronounce if you're not used to them, let alone anything else. And I don't think it's fair for us to expect general practitioners to be able to manage all the toxicities of all the different treatments that we give in secondary care, particularly as they are becoming more and more specialist. So this is a really, really useful website that I just want to signpost you to. It's actually called the BC Cancer Drug Index. So if you go onto that website, it actually it lists all oncological think of. So if your patient is on anything, you can find it on that website. And what it does, on the left here is the first part. It just gives you some information about the name of the drug, its mechanism of action, the pharmacokinetics, the indications for it, and then it gives you a big, I've only just shown you one small example of it, but it gives you all of the different side effects, the most common side effects, and the ones that are far more rare as well. So it's a really, really useful reference point for you. Next slide, please. So obviously in gynecological cancers, we've been using chemotherapy for a long period of time, but over the last couple of years, we've started to use more and more of a class of drugs, PARP inhibitors. So these are used in the maintenance setting treatment of ovarian cancer after patients have had after they've responded to chemotherapy. There's three main PARP inhibitors, the olaparib, niraparib, and rucaparib. And in terms of efficacy and toxicity, they're used in slightly different scenarios, but the toxicities there's a lot of overlap with them. One of the really important things to say, and where you can really reassure your patients, is that there's been a lot of work done with patient-reported outcomes, and a lot of the toxicities that these patients experience with these medications actually settle down after the first month. So if patients see you struggling if they've started on these medications, it can be quite reassuring for them to hear that actually, although they may feel quite nauseated now, and we obviously give them antiemetics, they may be very, very fatigued and have a headache. Most of those symptoms settle completely within a few weeks of treatment. And then actually, a lot of patients can actually tolerate them long-term, continue working in the younger population, and actually manage their lives without very much interference at all from the medication. So I thought that was quite a useful point for NGP to reassure the patients. These drugs are can be very myelosuppressive. They can cause liver and renal impairment. That's often transient, and it doesn't necessarily mean that we have to stop the medication, particularly if it's a transient increase in the alkaline phosphatase or the ALT. It often normalizes without any treatment or intervention and without any interruption of the drug as well. The rare condition that PARP inhibitors can cause is myelodysplastic syndrome. It's not very common. It's only a few percent. And actually chemotherapy causes myelodysplastic syndrome in approximately 2% anyway. So it's focused on, but it's not a huge problem in reality. Next slide, please. So immunotherapy, I don't know if you've had a separate talk on immunotherapy. We're not using it very much in gynecological cancers, but we're starting to. We're using it in MMR, deficient endometrial cancer, which is a specific cohort of patients with endometrial cancer. At the moment, we're only using it in the metastatic setting or in patients who've got advanced disease, but there are trials coming out in the adjuvant setting as well. It's used in a targeted group of patients with, again, recurrent or metastatic cervical cancer, and they have to have a PD-L1 positive disease. There's no role for it in ovarian cancer, but it's been trialed in a number of settings. Now, immunotherapy, if you read the side effects top sheet of it, it is quite scary, to be honest, because it can cause inflammation of absolutely anything. Next slide, please. So you name an organ in the body and add an itis to it, and it can cause it from, as you can see there, absolutely everything from myocarditis to encephalitis to nephritis, everything. The important thing is to recognize and manage these toxicities early. All patients starting on immunotherapy have a baseline cortisol level and a baseline thyroid function test, because hypophysitis is really, really important for botulism. And I'll talk a little bit about that in a minute. Some of them, the low-grade conditions, particularly the dermatitis, can be managed in the community, but really we would always want to know about it. Or I'm sure all my colleagues would agree that we would always want to know about it. Obviously, immunotherapy the toxicities of it are treated using steroids when they get really, really severe to try and dampen the immune response that the immunotherapy has caused. Next slide, please. I'm trying to be quick. So just in terms of dermatitis, because this is something that patients may come to see with you. So if they have a if they have a low-grade dermatitis, which isn't affecting much of their skin, sorry, next slide, please, it can just be treated with emollients. And if they're having a particular issue with pruritus with antihistamines. Once it gets to more than a grade 2, where the area of skin affected is greater, then really we need to be starting to use topical steroids. And if it's any more than that, it's going to be oral steroids and referral to dermatologists. But most of us would want to know much, much earlier than that. The other most common types of itises, if you like, or the most common toxicities that we see are colitis and pneumonitis as well, actually. In terms of colitis, obviously, initially it's supportive treatment, increase in fluids. Again, a close working relationship with the oncology team. I know we don't use very much in immunotherapy, but a lot of colleagues in other sites, such as melanoma and lung, use much more. But we would always want to know if our patients are struggling with these significant toxicities, because they can make the patient ill quickly. If the colitis is more severe, then the treatment, they need to be seen even as an outpatient in Velindre, and start oral steroids. And if it progresses, methylprednisolone and even infliximab. For the colitis, we then get the gastroenterologists or the surgeons involved, and have an early CT scan with anybody with pneumonitis. I've just put adrenal crisis there because obviously that can be severe and it can be life-threatening, and that's actually can be quite difficult to diagnose, because when patients present, their only symptoms sometimes is just fatigue, sometimes a little bit of sickness, sometimes a headache, and this can be life-threatening. A short synaptic test that isn't actually useful, so the test to do is a 9 AM cortisol level, and cross-reference that with the ACTH and the immediate start of high-dose intravenous hydrocortisone. So again, early referral discussion with us, please. Just a quick note about hepatitis and nephritis. That's seen very, very commonly, and similarly to the PARP inhibitors, often that can just be transient and the patients can carry on with their treatment and it normalizes. So we don't always have to get into too much of a panic with that. These patients should be being reviewed regularly anyway, but we would want to know if any of our patients' liver or renal function had deteriorated significantly. Next slide, please. So I think the next slide is just about HRT, and I thought Sarah is just going to talk about that. So just to talk about it ever so briefly, just because it is so topical. Any patient who hasn't had natural menopause should be offered HRT if we've iatrogenically put them into an early menopause. So that's particularly in patients with cervical cancer, because they're often young. If they've had a hysterectomy, they can have unopposed estrogen, but if they've got a womb in situ, then it needs to be a combined approach. There isn't very much evidence. The trials that have all been done looking at hormones in cancers are small, and we are trying to get this work going on with the British Menopause Society and trying to develop some trials actually looking at this and which of these patients can have hormone replacement therapy. At the moment, we are a bit twitchy about giving it to anybody with a hormone positive endometrial cancer, understandably. If that cancer is being driven or was driven by hormones, we are a bit twitchy in that. In ovarian cancer, it's controversial. Most people think that HRT is safe if it's not a hormone positive cancer. And often the most common type of ovarian cancer, high-grade serous cancer, isn't. So we think it probably is safe in that. And it often comes down as well, doesn't it, to quality of life and the symptoms that the patient is getting. And it's everything we do in medicine is a balance of risks and benefits, isn't it? Next slide, please. So just one other slide about hormones. We do use hormones in the management of gynecological cancers, particularly Provera, so progesterones and estrogens. We use tamoxifen and anastrozole, obviously not as much as our breast colleagues, but we still do. Why I've put this here is because often we will send you letters asking if you don't mind checking our patients' blood pressure and weight, because particularly Provera, it can cause an increase in blood pressure. In endometrial cancer, these patients, as everybody knows, often have a problem with weight anyway, and we're starting them on a medication that can cause weight gain, which sounds a bit counterintuitive, doesn't it? But having said that, sometimes patients have incredible responses, and we've seen patients with metastatic disease treated in excess of 10 years with hormonal therapy. So it's a really, really useful treatment. And again, those patients, particularly if they're only coming, if they've been on treatment for many, many years, they're not coming back to Velindre regularly. So that's where it's really useful to link in with you if possible. And we are very grateful if you can check their blood pressure. Next slide, please. I think that might be the last. I'm sorry if I've gone a little bit over, but a massive whistle stop tour. I hope it was, some of the points were useful. Oh, sorry, one last slide. Just another weird and wonderful that you might see. This is a group of drugs called tyrosine kinase inhibitors. We use trametinib for low-grade serous cancer. That can cause diarrhea and a skin rash. The skin rash is incredibly common. It does usually respond to emollients or clindamycin. If they don't work, we can use oral antibiotics. And if that doesn't work again, we go to steroids. It's very, very manageable. Sometimes it does need treatment breaks or dose reductions, but again, it's about reassuring the patient that this isn't going to stop their treatment, that we can manage it. Often it's in the scalp, and unfortunately often affects the face, which is obviously a bit more distressing for the patient, but it is manageable. So you may, it's rare, but these cancers are rare, but these toxicities are common, so you may well see this. Thank you, and that is definitely the last slide, I think. So thank you.
Emma, thank you, and wonderful whistle stop tour, but thank you so much, particularly just thinking of the issues around what people are likely to see in the community. We have no questions or anything in the Q&A, and in the interests of time, I'm going to go on if that's okay, but folks, please, just as you think about things, put them in the Q&A. I'm also aware that we're heading towards 2 o'clock, and Louise is still to speak, and then Sarah and Tamara are still to speak. We understand that you may have things that you need to go and do at 2 o'clock, but we are recording this session, so the fuller session, if you have to leave early, will be available on YouTube. Louise, welcome. Thank you so much for joining us. Over to you.
Thank you, Fiona. Can you hear me?
Yes.
Brilliant. Okay. So I'm Louise Hanna. I'm one of the consultant oncologists in Velindre. And I'm going to talk to you about two things. One is cervical screening. So we're just going to slightly backtrack to the diagnosis stage, and then just talk a little bit about late effects of cancer treatment. I'm very conscious of the time, and as the other two speakers have said, Sadie and Emma have said, there's no way that this is probably a week's topic, so there's no way that we can do it justice in 10 minutes, but hopefully we can just give you a little bit of a flavour about it. So can we have the next slide, please? I wanted to talk about barriers to cervical screening, but Elise mentioned maybe it might be an idea just to update on the new screening frequency, because that has changed very recently in Wales, and it is different in different countries. So just be aware of that. So whereas screening used to be every 3 years, it's now moved to every 5 years. And the reason for that is that it's now done with using a test for HPV, the virus that causes cervical cancer, and that is a more sort of sensitive test. And basically, if a patient is HPV negative, then they're not really going to be, they're very unlikely to be getting cervical cancer. So the move to HPV testing happened a few years ago, and then more recently the screening has moved up to every 5 years. So you might have some patients asking about that. I know it did cause a little bit of a ripple in the communities when it moved to 5 years, and there was some anxiety, but the reason is because it's a more sensitive test. There are some exceptions for that. If patients are on follow-up after they've had changes detected, if they've got HIV, then they would have annual screening. And if patients are over, or individuals are over 65 and they've never had a cervical smear, then they would be eligible for smear. So cervical screening is anybody is eligible. So this is women and people with a cervix as well. As Emma mentioned, the LGBT community. So there may be some people who identify as men or other who would be suitable for cervical screening. Just to reiterate that if patients are symptomatic, then they should be examined and referred if their cervix is abnormal. So cervical screening is really for people who are asymptomatic. Next slide, please. So with cervical screening, it's now done with a soft brush rather than with a spatula, and it looks basically for high risk HPV. And if that is negative, then the repeat is not needed for another 5 years. If the HPV comes back as positive, it's only then that the cytology is looked at. And if it's normal cytology, then it would be repeated in 12 months' time. If there's dyskaryosis, then the individual would be referred for colposcopy. If there's not enough cells, or if for some reason the result is not available, then the screening would be repeated in 12 weeks. So the patients or the individuals get into the system that way. Next slide, please. I did want to talk about some barriers to cervical screening, because there are some women who don't undertake screening, and as Emma mentioned, some of these patients then do sadly present with advanced or locally advanced cervical cancer at a later date. This is taken from the Joe's Trust website, and you can see there are a lot of different reasons why people might not be able to have cervical screening. They might be very embarrassed or have pain. Sometimes there might be cultural issues. They might even be worried that they might know the person taking the screen. They might not understand what it's for. It might be difficult if the individuals had FGM in the past. And there may be other factors like convenience, and patients who have a physical disability might have difficulty. So if we go to the next slide, please. So I did want to mention vaginismus, and the reason that I wanted to mention this was due to a patient that I treated a couple of years ago. And you wouldn't really think of vaginismus as being a fatal disease, but unfortunately this person was unable to have cervical smears because of vaginismus, and at the time that they weren't able to have cervical smears, they didn't really know what vaginismus was. All they knew was that they were unable to have a smear, and they made the point, they were very eloquently well-spoken individual who made the point that often when patients or individuals don't have screening, they're often sort of labelled as being weak or weak-willed or not engaging. And here was somebody who did want to engage with their care, but was just physically unable to. So there's two different types of vaginismus, primary or secondary, which may be secondary to infection. And there are risk factors for vaginismus, such as a previous sexual assault, which was very relevant in the case that I've discussed, endometriosis, vaginitis, or previous episiotomy. So treatment can be given in terms of treating infection, but equally a lot of support can be given for the appointment, and the patients might find particular position more comfortable. Relaxation and mindfulness can be helpful, and sometimes if necessary, patients might benefit from psychological support. So I'm sure that in your practices you will have patients who haven't had cervical screening, and it was really just to highlight some of the barriers, so that if you have the opportunity to support patients in that, you're aware of that, and I'm sure you are aware. So this is just to kind of reiterate that. Next slide, please. So I wanted to talk about the late effects of cancer treatment. And again, it's an absolutely massive topic and it's impossible to cover in 5 minutes. So basically, half of all women who are diagnosed with cancer will survive for 10 years or more. And there are 1.8 million cancer survivors in the UK. So that's increasing numbers of people who are living with and beyond cancer. Obviously, we've got different forms of treatment, surgery, radiotherapy, and we call it SACT, which is systemic anti-cancer therapy, which is basically any drug, anything that goes systemically. So it could be chemotherapy, it could be the biological treatments, immunotherapy that Emma was talking about earlier, or even hormonal treatment. Next slide, please. So at a previous meeting, we asked GPs, would you, if you see a patient, would you typically know that that patient has had a previous cancer? And it turned out that the vast majority of you would know from the read code or the summary or a problem list, but some GPs are not aware of a previous cancer diagnosis for their patients. Then the next slide, please. So we then asked, would you know if the patient, you might know that patients had cancer, would you know if the patient had previous radiotherapy? And in fact, the vast majority of GPs answered that they wouldn't automatically know that the patient had had previous radiotherapy. So if it had been coded that they had had that, or if it was in the summary, but otherwise it would mean having to search the medical records, I guess, ask the patient to find out what previous treatment they've had. So that does mean that it can be difficult perhaps to identify and treat and refer patients who've had complications of their previous treatment, because obviously, you know, it's been alluded to before, you know, it's, I think you have 6 minutes per patient, and to cover everything else that is increasingly being expected of you, it must be really hard to be able to focus down on this. And obviously you might not always be aware of the previous treatment that patients have had. The next slide, please. So when patients who've had a previous cancer develop symptoms, sort of 3 main areas that it might be causing those symptoms. One is they might have a recurrence of their cancer, sadly. Might be late effects of cancer treatment, or the symptoms might be completely unrelated to the cancer or its treatment. Obviously, the fourth one as well is that they might have developed a completely separate new primary cancer, which can happen as well. So we go on to the next slide. So just to talk about the different sorts of late effects that we can see, I really wanted to put this list up just to show the absolutely huge diversity of symptoms that patients might have. This is specifically looking at, or a lot of it is looking at pelvic radiotherapy, but equally a lot of these are relevant to surgery as well, and some of them to chemotherapy. So the patients can have a great variety of gastrointestinal symptoms. With pelvic radiotherapy, it's mainly lower GI symptoms, but sometimes patients can have bowel obstruction, and so they can have upper GI symptoms as well. And sometimes when we treat with an extended field for cervical radiotherapy, that might actually go up into the para-aortic region, so it might affect the upper bowel as well. The main urological symptom that patients can have is urological incontinence, but they can also have bleeding due to previous radiotherapy. A lot of patients can experience peripheral neuropathy, particularly secondary to chemotherapy. If they've had ovarian cancer, the Taxol chemotherapy can notoriously cause that, and do everything we can to minimise that, but unfortunately some patients do end up with long-term neuropathy. Obviously, a lot of our treatments do unfortunately cause an early menopause in our patients, and so there may be hormonal effects. And lower down, I've mentioned osteoporosis as well, which can be an effect if patients have an early menopause and don't have any bone protection. They can be affected by body image, obviously having a hysterectomy or having radiotherapy or surgery to the vulval area can cause huge issues with body image. Patients might have lymphedema, swelling of the legs due to disruption of the lymphatics from surgery or radiotherapy. And there might be problems with the vagina, such as atrophy or telangiectasia, so patients might have bleeding. The other thing patients often have after radical radiotherapy is they may have pain as well. That always causes a worry as to whether they've got any got a recurrence. But sometimes if you know, for example, if you've had a locally advanced cervical cancer and that all shrinks down and you get an awful lot of scar tissue, particularly if you've had lymph nodes which have been maybe pressing on the nerves, etc. Sometimes patients do remain opiate dependent after the treatment for some months afterwards, and it can take a long time before that pain settles. So that's just something to be aware of, because sometimes patients end up being on much higher doses of opiates than we would normally expect to have in general practice, particularly if their cancer's actually been treated and cured. And then obviously patients can have non-specific symptoms. We have a lot of patients who have fatigue or stress or depression, which can occur with any cancer. Next slide, please. So if we're investigating, one of the first things we do is, has the patient got a recurrence? Have they got any, I think in general practice, have they got any red flag symptoms which would warrant an urgent referral to secondary care? If they haven't got a recurrence, then we would undergo symptom-led investigation. There's a lot that we can do in terms of managing symptoms, but we can also investigate. And one of the successes in terms of how we investigate is the Royal Marsden algorithm for investigating bowel symptoms, which is basically systematic investigations that can occur in order to identify the one or several conditions that may respond to treatment. So we would encourage you to refer patients with difficult symptoms to the specialist team. And in Velindre, we do have a late effects service where we have, so we have our gynae specialist nurses, gastroenterology and physiotherapy for urological symptoms as well. And it's a sort of one-stop service where we provide holistic care and support for patients. There are lots of resources. This is the Macmillan booklet, which is mainly for patients, but it's also a fantastic resource for healthcare professionals as well. And there are some web pages on the Macmillan website as well. Next slide, please. So I just wanted to explain or just talk about it. This was a typical patient that we might have. So she's a 63-year-old lady. She had pelvic radiotherapy 2 years ago for vulval cancer, and she's now got intractable diarrhea. And so she is referred to the late effects service and is investigated by the gastrointestinal specialist nurse, who does several investigations, including a CCAT study, which actually confirms that the patient has bile acid malabsorption. Particularly with pelvic radiotherapy, the terminal ileum can be affected, and so patients can get problems with malabsorption from that. And this particular patient had a great improvement in their symptoms from cholestyramine, and they obviously patients, it can sometimes be life-changing to have these treatments. They might be completely housebound with their symptoms, and if they have adequate treatment, then they can, then their lives can really be turned around. Next slide, please. I just, in the last sort of minute or so, I noticed some of the questions that have been submitted also did talk about sort of palliative care options. So I just wanted to just list really a few things that can occur. And sometimes these symptoms can be, you know, mixed up with late effects. And sometimes they are multifactorial as well. So you might have a patient who's got bowel obstruction due to late side effects, plus they've got a recurrence, equally with a fistula. So obviously the palliative care team is incredibly important here. The community palliative care team are fantastic, and I really, you know, during the COVID pandemic, the community palliative care team have been particularly helpful in our patients when they weren't able to come to hospital, so home visits are very good. One thing I did want to point out was about pain, because a lot of our gynae patients have very difficult pains to control if they do have a recurrence, and that's because the recurrence recurrences are often in the pelvis. They might cause nerve root compression. And the other thing as well, which isn't talked about very much, is psoas muscle involvement. So if you have a patient who's kind of walking all stooped over, or they can't straighten their leg, it might be that they've got a lymph node recurrence, which is actually involving the psoas muscle. And so every time that leg is straightened, they've got an awful lot of pain. And these pains can be very difficult to control and often need adjuvant painkillers as well as opioids. I think that's the end of my talk. Yeah.
Louise, thank you
very much.
That's been very helpful.
Sorry, it's been such a whistle-stop tour, but if there are any questions, I'd be happy to take it.
We haven't got questions at the moment come through on the chat, so I'm going to keep on going. But as again, people viewing this at a later stage, you'll have got the whole flow of the session. So last but very much not least, and thank you so much to Sarah and Tamara for joining us, but also for waiting. But this is an incredibly important and quite challenging area for healthcare professionals to engage with. So thank you very much, you two, for joining us and just enlightening us about some of the psychosexual problems with the gynecological cancers. Welcome.
Thank you, Fiona, and thank you for asking Tamara and I to present. So I'm Sarah Burton. I'm one of the gynae cancer specialist nurses in Velindre, and this is my colleague Tamara Jones. There is a third gynae cancer specialist nurse, and that's Fran Jones. So there's three of us who work with our three consultants based here at Velindre Cancer Centre. Next slide, please. So we want to talk to you today about psychological issues with our gynecological cancer patients. And for too long, unfortunately, they have kind of been swept under the carpet, but not within the gynae oncology team. It's something that we all feel very passionate about, and we want to address any concerns and issues as they appear along that patient's pathway, rather than just waiting until the patient has lots of problems, which may then mean that we're not able to help and intervene as easily as we would have been had we known about it earlier on. Next slide, please. So I'm sure you all know this, but just as a quick recap, a reminder, what is sexuality? Sexuality is how people express and experience themselves as sexual beings. Sexuality is personal to the patient and is part of their identity. And sexuality is much more than the physical ability to have intercourse. Next slide, please. So as it has already been discussed by Emma and Louise, you know, some of our treatments will induce an early menopause for our patients. Now, whether that's a surgically induced premature menopause or chemotherapy induced menopause, obviously for our young women who are treated with chemotherapy, for those young women, their periods may stop for a period of time, but providing they haven't had any radiotherapy, then for the majority of those young women, their periods will then restart. But certainly if they've had surgery, or if they go on to have pelvic radiotherapy or sort of combination of surgery and pelvic radiotherapy, then sadly, you know, they do have a radiation-induced premature menopause, which is permanent. Next slide, please. A little bit of myth busting. Some of the things that our patients have been told by their GP practitioners, who I'm sure meant well, but maybe just need to have a little read up or come to more sessions like this. You're young, you won't have started the menopause yet. You've had cancer, you can't have HRT. Now, as Emma explained in her talk, there are certain types of estrogen-driven hormone replacement, estrogen-driven cancers, which we wouldn't want to give HRT to, but the ones that are not hormone driven, and in particular our cervical cancer patients, there's no reason why we can't give them HRT. And I feel very passionate about this, and I actually think it's cruel if we weren't to give it to them or even offer it to them in the first place. Another one is you must have the oral combined HRT as the other preparations are not available. And I'm sure you'll all be aware of the national shortages that has been going around, and it's affected us probably during the pandemic, but also with Davina McCall and her programme, was it on Channel 4? That certainly got everybody talking about the menopause, got more women interested in it, but also I think to be able to challenge maybe going to see their GP and say, why can't I have it? And certainly for a few of our younger patients, cervical patients, they've gone after we've had a lengthy discussion about HRT. We've discussed the different types. We're members of the British Menopause Society, so we're aware of, you know, the new types of HRT. And sadly, we've had two ladies that came back and said, I can't have the gel or the new micronized progestogen because my GP only knows about the combined oral preparation. So I think, you know, there's a little bit more needs to be done education-wise. Another one we had recently, which the patient was really upset about, again, another cervical cancer patient. We always do a hormone profile at 6 weeks follow-up appointment, just to dot the I's and cross the T's, really. We know, because their ovaries and their endometrium's been ablated, that they will be postmenopausal. But one GP told the young patient, we'll recheck your hormone profile in 6 weeks, just in case your ovaries wake up. And the patient, bless her, said, no, I've been told my ovaries won't wake up and I would like my HRT, please. And some other sort of quotes from our patients, they've been told your menopause symptoms will settle soon. Well, for anyone that is of a certain age, and I include myself in that age, menopausal symptoms on the whole do not settle down quickly, you know, and it can range from between 2 years or 12 years. And for a small minority of women, they will last for the rest of their lives, and they are really debilitating. So again, I think maybe a little bit more reading around that subject. Can I have the next slide, please? So this is the pathway, just to give you, probably think, oh gosh, there's lots of boxes, but just to kind of show you what happens with our patients. Diagnosed at the central MDT, they come in, they have their first consultation where the diagnosis is explained, treatments discussed, associated side effects. So whether it's fertility issues, menopausal issues, all the toxicities we would deal with at that consultation. They then come for a second consultation, seen for consenting, rediscuss the diagnosis, treatment, toxicities, and any other questions they may have. At that point, they've already had a consultation with the CNS team. Since COVID, the majority of those consultations have been on the phone, but we are looking to try and rebalance that a little bit more. They would then go off, have their treatment, and then they come back and they're reviewed in a consultant-led clinic 6 weeks post completion of their treatment. And in particular, we're talking about our cervical cancer women. It's during this consultation, as Louise explained, we would look at sort of pelvic toxicities. They're not quite at that 6 week point. It's expected for them to have toxicities, but they don't fall into the late effects bracket. So we would be expecting things to improve. We would also, as I said, carry out the hormone profile. We would be talking to them about HRT, different types of HRT. Then they, I've just noticed I've gone the wrong way for the sorry. At the end of their treatment, whether that be chemotherapy, chemo RT, brachytherapy, or a combination of them all, they would be given a pack of vaginal dilators post radiotherapy, and they would be educated regarding their use. So not all women wish to dilate, so we don't put pressure on them. We're not ageist. We basically talk to them about if they want to have a patent and working vagina, the dilators will certainly help them in the first year post-treatment. But if they don't want to dilate, then that's absolutely fine. Once the patients then have their hormone profile done, we would then contact them via our nurse-led clinic. We would discuss vaginal toxicities with them and refer them on to our nurse-led psychosexual clinic, which is run the first Thursday of the month. This clinic was set up 11 years ago. We would then write a letter to the GP requesting HRT, and we're also quite specific in the type of HRT that we've discussed with the patient. So if the patient needs an unopposed estrogen, we would explain that, whether that's in gel form or transdermal. We're now, moving away from the combined oral preparation. There are much better modes of delivery of the HRT available now than the oral type. So we would obviously put that into the letter. We obviously don't go into the branding of it because we feel that would be a little insulting for our GP colleagues. But we always say in the letter that if they require any more information from us, to please feel free to get in contact. And we would, the patient then continues on the consultant-led follow-up, plus or minus any late effects of the pelvic radiotherapy team, which, as Louise said, we're part of, or whether we need to also see them alongside in our nurse-led psychosexual clinic. Can I have the next slide, please? So this is our clinic. It's a self-referral or a clinician referral service. We see patients who are experiencing dyspareunia, vaginismus, as Louise explained earlier. We often find if we do have a lady with vaginismus, through counselling and the use of our vaginal dilators, and you can see the pack in the top right-hand corner. They're called Amiel Care, and we give these free of charge to all of our patients who receive pelvic radiotherapy. If they want a different type, sort of silicone made vaginal dilators, as you'll see bottom right corner, the pink ones, which do look slightly odd, but they work very well, and they're a lot more comfortable for our ladies who have received vaginal brachytherapy. We also deal with vaginal atrophy, vaginal stenosis, altered body image, and of course menopausal issues. We've run this service now for 11 years. Initially it was just open to our Gynaecology patients, but over the last few years we've actually been asked by our colorectal, urology and sarcoma teams if we would see young or complex female patients in this clinic, which we do. We signpost and use, I'm sure you've all heard of Dr. Louise Newson and her Balance resource app, which is amazing. The information in there is great. Patients find it really easy to understand. So we use a lot of her information. We also signpost any of our ladies who have any dribbling incontinence post-radiotherapy. We have got a women's health physio, but she's been not available. She's been sick for the last few months. So we've had to be quite resourceful, and Fran, our other specialist nurse, actually downloaded the Squeezy app, which is available for £2.99, and it's absolutely brilliant. It explains how to do your pelvic floors and also gives you a little reminder on your phone. We'll also signpost to our menopause cafe, which is run in Velindre. And I think last but not least, you'll see some pictures of an organic vaginal moisturisers that we prescribe. We've been using these moisturisers for the last 7 years. We've got brilliant results with them. We also use an awful lot of topical estrogen as well in this clinic, just to try and regain the vaginal patency and comfort. I don't think I missed anything on time. No, it's forgotten. Last slide, I think it's the last one. Next slide, please. Yes. So it was a very quick talk on the psychosexual problems that our patients have and how we can deal with them. But just for a resource for you to know, if you've got a patient that's under our care, has any psychosexual issues, please feel free, drop us an email, give us a call. We'd be more than happy to help you. Thank you.
Thank you so much. Thank you, Sarah. Thank you, Tamara. Thank you, Francis. It's very much last but not least, as I said when you started talking, and of course this session is being recorded, so many folk I know will be looking at this following this live recording, so we'll have access to this information. And I guess we're lucky in Cardiff, we're lucky the people who are around Velindre, because you do provide this fantastic service. I guess if you're looking at at this recording and work elsewhere, then it's worthwhile inquiring from your local gynae-oncology teams, what is there that's similar. So we haven't got any specific questions, but I think this has been a real example of how this is a team activity. This is multi-professional working. We need everybody involved in looking after ladies with gynecological cancer, people with gynecological cancer, from the community right through secondary care, right through the oncology services. And it's very much that team working, the role that the new clinical nurse specialists can bring to the patient care, the different teams can bring to patient care. So I hope that, yes, it's gone on longer than the other sessions, but I hope that this has been a really useful, in a sense, overview. And we would be really keen to have feedback. If you've attended the session today, if you're looking at it online, we would be really keen to have feedback. We're also aware that people's practice is now changing in terms of how they access education and CPD, so we'll be asking about that as well. So it is 2:30. I'm going to say particularly thank you to Sarah and Tamara for staying so long and getting us here to the end. But thank you to all our other speakers, to Emma, to Sadie, to Louise. Thank you to Mick and Elise for setting these up. And thank you to Charlotte for organising things. Have a good day, folks. Very good of you to join us. We're going to